I'm Dr. Patel, Director of Head and Neck Surgery here at Mercy Hospital, and today I wanted to just do a brief introduction and talk about tracheostomies in general, in terms of what a tracheostomy is, what it's used for, the anatomy of a tracheostomy. So a tracheostomy is an airway that's directly below the vocal cords, directly into the trachea. It's a surgical airway, and instead of your normal endotracheal tube, which is either through the mouth or through the nose into the trachea and crossing the vocal cords. And so that's called a translaryngeal intubation. So this basically is a situation where the tube is placed below the vocal cords and the ventilator and circuit is connected to provide airflow below the level of the vocal cords. Why do we use tracheostomies? Several reasons: any sort of obstructions, tumors that are obstructive, neurological injury where patient loses the ability to breathe for centralized reasons, patients who have had trauma to the airway or not, patients who are septic, and there's a variety of other reasons, and surgery in particular, which is an important topic for me. Sometimes we'll do tracheostomies in order to protect a patient's airway for the immediate time after surgery, and then with the plan of decannulating the tracheostomy and removing it at a later time once their airway is deemed secure. So this is what a tracheostomy tube looks like. So basically this is called the Shiley trach. This is the tracheostomy tube. This is the cuff. This is called the inner cannula. And generally when you put this in, it should click into place and shouldn't move. So this is the pilot balloon, and this will inflate the cuff. So I generally take a 10 cc syringe, draw up air, and attach, and then you will see the cuff inflate. If it doesn't enough, detach it, get some more air, and inflate the cuff, and you'll see the cuff will inflate. Now you generally want to inflate the cuff just to what I call doughy consistency, not too hard and not too soft. And the reason why we have a cuff is to create a closed circuit for the ventilator. So if a patient needs positive pressure, you need to create a closed circuit where the air goes from the circuit into the patient's lungs, and comes out this way, and there's no air escaping. Remember, the mouth is up here. There's no air that's passing this way. It creates a closed circuit. And so this occludes essentially the rest of the airway and provides just one pathway in and out. That's the point of a cuff. So you cannot have a patient on a ventilator without an inflated cuff trach. In terms of the cuff pressure, you want to make sure you don't put too much pressure in there because that can erode the mucosa, cause irritation, can cause later on tracheal stenosis, even in the worst case scenarios, tracheoesophageal fistulas, which can be life-threatening. So you want to make sure that you put in the right amount of air. There are trachs that are cuffless, and so in a patient who does not need a ventilator, you can use a cuffless trach. It will still provide a secure airway, however, does not create a closed circuit, and so cannot, you have to switch it on to put a cuff in order to put a patient on a ventilator. There are a couple ways that people secure tracheostomies. One is sutures, usually 4, one on each corner, and sometimes, most often, you'll see with trach ties or trach collars that are around the patient's neck. In my particular patients, as I'm sure a lot of you have seen, I don't use a trach collar. I will suture them, primarily because I've operated on the airway. There's a flap with a vascular supply in the neck, and so you don't want to squeeze the blood vessels that are feeding the flap, kind of similar to not putting a blood pressure cuff on an AV fistula. Because you could compress it. In the next video, I'm going to talk about tracheostomy care from a nursing and respiratory therapy standpoint.